drive from Miami, so just the traffic, some unpredictable things came up, and I was sort of panicking. I wanted to make sure I got here. So let me give you a little bit about my background. I started working in cancer about 26 years ago, and at the time when I received my training, I really focused more on the emotional part. And then after I had been practicing for about 2 or 3 years, I realized that people would come in to see me for depression or anxiety, because that's why they were being referred. And I was the first person to ask them, has there been any change to your sexual life? So we're going back about 23 years ago, and people would just open up and start talking to me. And what I realized at the time was that I didn't really know a whole lot. And so I went, I got trained, and I then started to really be able to offer more of the services. I also realized that, most people, when you're initially diagnosed, your immediate concern is for your life, right? You're in fear for your life, you want to know about treatment, and that's the focus that the oncologists have as well, of course. So what I realized then is that as people start getting towards the end of their treatment and they start going back into their life, then you start thinking, what is my life really going to be like? So I've survived, but how have I survived? What is my life, again, going to be like? And that's where I think often the thoughts about you as a sexual being come into question. So I know we have here a combination of men and women, and we have different types of cancer that people have had, correct? Okay, so just so you can keep in mind, I'm going to cover in an hour a lot of material. If I'm going too fast, please feel free to interrupt me. I'm okay with interruptions. And also keep in mind that usually what I do is I meet with people individually and I provide psychotherapy, individually or as a couple. So what I'm going to give you are very general suggestions and general information. So feel free to stop me. Let's see. See, already I'm. Okay, so that's the. Oh, I got to do here. No. Just going to hit right here. Where? That arrow. Oh, that lever. Yeah. Okay. Okay, so now we're going to look at the general population. I'm going to start with women and go back to men and then forward to women again. In terms of the general population, 1 out of 3 women report low sexual desire. So that's the general population. This is not necessarily anybody that has gone through any cancer treatment. 40% of women, by the time that they reach menopause, 40% will report a decrease in their libido or in their sexual desire. And part of that may have to do that with the levels of testosterone. And testosterone is what is responsible for sexual desire in both men and women. By the time that women are in their 40s, their levels of testosterone are half of that of women in their 20s. So you can see that by the time menopause comes about, natural menopause being somewhere about 52, of course, when you go through cancer treatment, depending on the type of cancer, it may be premature. You may go into menopause. I'm going to talk first a slide. I'm going to have a slide about the different types of cancer. If you look at breast cancer, you can see here, in the slides people will say are old. Yeah, but that doesn't change anything, because the problems that women are reporting or the difficulty sexually, that hasn't changed, because our treatments have not changed. You're still receiving chemotherapy. And honestly, while there have been more chemos available for breast cancer, you're still receiving chemotherapy. And so you'll see that it's very common after chemotherapy, particularly, for women to report some change in their sexual life and their sexual functioning. You can see that about 60% will report a decrease in the interest in sex. You will see that a large percentage, the last one, painful intercourse, reported at 11% before chemo, 44% after treatment. So painful sexual intercourse is common, decrease in desire. These are all very common types of complaints that women may have. And I should say may, because I do have women who report no change. One of the things that I'm often asked is if there is a difference in terms of sexuality between women who have a lumpectomy versus a mastectomy. And actually, going back to just psychologically, we have found that there is no difference psychologically between women who have a lumpectomy versus a mastectomy. Because regardless of the surgery, the fear, the distress, the emotional upset is the same. Because what affects women is the fact that they got cancer. And that's what makes them fearful and scared. So the worry about recurrence, the same, regardless of surgical procedure. The only difference is that for women who've had a lumpectomy, they report better body image and more sensation, which makes sense because if your breast isn't removed, then you still have sensation there. Obviously, when you're reconstructed, the sensation is different and perhaps not quite at all what it used to be. In terms of gynecologic cancer, ovarian cancer, again, when you look at the sexual life, that can have a major impact for ovarian cancer. 50% report a negative impact, and 75% say that their sex lives are adequate to poor. Cervical and endometrial, again. And a lot of these problems for cervical and endometrial have to do with the radiation. Because if you get cervical or endometrial cancer, you'll often get radiation. And the radiation sometimes is done where you can receive some internally, and what happens there is that you get a lot of scarring, and that can have a major impact. And again, we'll talk more about that. And this was done a long time ago, 1997, but I always ask people to raise their hands. 81% of breast cancer survivors were never asked about sexual concerns by their healthcare providers. And while this was done so many years ago, 20 years ago, I doubt that that has changed a lot. How many of you were asked about your sexual life at some point during your treatment? Was anybody asked? No. Okay, so you can see that, again, 20 years ago, only 81% were never asked, and I think today the numbers are still the same. It hasn't changed a whole lot. It's not something that is addressed by healthcare providers. I have theories, and I think some of the theories with that have to do that it's not associated with cure, and the focus that the oncologists have obviously is with curing you. So if you've survived and you're alive, well, that's their focus. Another reason is if they ask and you say you have a problem and they don't know what to do, then what are they going to do with that information? So then they're left, you know, with, okay, now you've told us all this, what are we going to do? And then I think that there's the discomfort for obviously both the people going through it and the providers sometimes, because they're scared of what you're going to say and how they're going to handle it. Now we're going to talk about men in the general population. So 18 million men report erectile dysfunction. So that's a huge number. This is general population. Why? Diabetes, cancer, cardiovascular disease. So erectile dysfunction is very common among men for many different reasons. The probability of having some erectile dysfunction increases with age. If you look here, if you're a man between the age of 20 or 40, only about 5% are going to report some erectile difficulties. But if you're over 50, just over 50, 40% report that, just over 50. And if you're over 60, after cancer treatment, then you're much more likely to have erectile dysfunction because the problems occur more likely the older you get. And again, that's not just cancer, it's diabetes, cardiovascular disease, obesity, all these problems that come about because of obesity. This is in terms of men, okay? And if you look here, this is the treatment. So chemotherapy, a hormonal treatment like men with prostate cancer may receive. Sometimes you have your testes removed here with bilateral orchiectomy, medications, okay, other medications that may be involved, radiation, okay? So if you get chemo, you may have erectile dysfunction and you may have a loss of desire. That is not uncommon for men. I will say this, regardless of the type of cancer, regardless of whether you're a man or a woman, and regardless of your age, when you go through chemotherapy, it is my clinical experience that there is a decrease in sexual desire, regardless. I always give the example of my little 27-year-old single guy who got Hodgkin's lymphoma and who was referred to me for depression. And as I started talking to him, he was single. A big part of his sense of self was related to him dating and being somebody who was sexual. And when he came to see me for depression and we started talking, it was really all about the fact that he had no sexual desire. And he was 27 years old. And he said to me, you know, if this is the way my life is going to be from now on, even if I survive, because lymphoma is the Cadillac of cancers, as he was told, you know, it doesn't, I don't know that I want to live like this. And at that point, he had tried, you know, self-stimulation. Nothing was really working. And I told him, it is often the case with chemotherapy. If 6 months to a year after you're still having this difficulty, come and see me. And didn't see him again, assumed he was fine. And I saw him one time in the lobby, waiting to be seen for a regular checkup. And he saw me and he said, A-okay, didn't need to come back and see you. So, you know, really chemotherapy has a major impact on just sexual desire. Okay, so now what are some types of hormonal interventions you can receive? You're a man, you can receive bilateral orchiectomy. Sometimes happens for testicular, sometimes happens for prostate, and you can see that's going to have, across the board, there's going to be side effects, because basically if they remove your testes, that's going to have a major impact. If you receive hormonal pills, some men get diagnosed with prostate cancer, and then if it recurs, they'll be given hormones. Again, across the board, you're going to have difficulty getting an erection, you're going to have dry orgasms. If you've already had surgery, you're going to have a weak orgasm or no orgasm if you haven't been able to even get an erection, and obviously a loss of desire. And these are all just common results of the treatment. And again, radiation you'll have there. And oftentimes men will report pain after radiation with sexual contact. Depending on the type of surgery, if you've had, on the very top here, if you've had colon cancer. I saw a 74-year-old man today who had stomach cancer. He had a major surgery done. Actually, his surgery was extremely successful 3 years ago. His surgery went so well, he didn't need radiation or chemotherapy, and he's basically survived. He's down now to once a year. But because of the surgery, he has erectile problems, he has dry orgasms, and they're very weak even when he has it. And dry meaning there is no, because of the type of surgery, no ejaculation. So, you know, he came in, I'm gonna have his wife come in next week and we're gonna talk, because he's very concerned that his wife is not getting enough from the relationship. And so I wanna bring her in. And here you have penectomy, cystectomy because of the bladder cancer, and prostatectomy, okay? So I'm going to talk mostly about prostate cancer because I think that's the most common type of cancer with men. If I don't address a type of cancer that you're interested in, then I'm more than happy to go ahead. But I'm going to focus on prostate since that is the most common type of cancer that men have. And with now more and more common that if men have a total prostate removal, more and more they're going for the nerve sparing surgery. That's what's really become much more common. And if you have nerve sparing, it can take up to 2 years for men to get back some sexual functioning. Why is that? Because up to 2 years, the nerves can regenerate. So you want to give time for that. There are things that you can do to actually make sure that you're helping yourself as much as possible, and I'll talk about that. Now, whether a man can have nerve sparing surgery really depends on the size and the location of the tumor. Obviously, bigger tumors, harder to go for the nerve sparing. Now, what they have found is that 50% of men have erectile dysfunction before surgery. Remember, the older you are, the more likely you are as a man to have some difficulties with erections. And prostate cancer is usually associated with increased age. So I actually have a very dear friend of mine whose husband was diagnosed now at 52 with prostate cancer, and he was diagnosed with advanced stage. So he did have bilateral orchiectomy, okay? He didn't have the prostate surgery because it was already spread. So they really wanted to remove the source of testosterone production, and he's 52. So they removed both testes, and they have given him high doses of hormones. He's 52, but he at this point is very clear that while he did not, he was 52, have any erectile difficulties before, he was a jogger, he was exercised, very thin, in great shape, he now has no ability to have an erection at all and no desire. And really that is medication. There's really not much that can change that because he needs to be on the hormones to try to control it. Now, whether seed implants or external beam, seed implants less likely to have erectile dysfunction than external beam and radical prostatectomy. If somebody goes through external beam radiation for prostate cancer, usually the man can function well at the beginning, and as time goes on, there's less functioning. So the opposite of surgery. And the younger you are at the time of surgery, less than 60, the better you are to do, or the better you will recover post-surgery. And there's now something where they're doing some nerve grafting and they're trying new things to see if that can help to prevent really bad problems afterwards. Did I see a question? What are the treatment options for erectile dysfunction? Okay, the most common ones that most men will try are medications: Viagra, Levitra, and Cialis. And I'm going to talk about all three of those and when you choose one versus the other. Now there's injections, and what these basically are the man actually has to use a very thin and small needle at the base of the penis, and they're going to put in a little bit of papaverine. And they do that, and that does cause an erection to occur. And that erection can go for quite a while. So men can go to the bathroom, inject, and come out and have sexual intercourse, okay? Obviously, for many men, the thought of putting in, even though it's a very small and thin needle, and at the base of the penis, so it's not right in the middle, in the base, is still very, very scary, which is understandable. And so the pellets is the same concept. Vacuum pumps is really not useful at all. It's using a vacuum, and you try to suck the air out of it and try to get an erection. And then there's penile prosthesis, which is surgery. Interestingly enough, the best results are obtained with injections or penile implants, but they're also the most invasive and the ones that can result in more complications or concerns for men, which makes sense. So they're less likely to be tried. Really, the things that most men will try are the medications, which are a good place to start. I always think that is where you should start. And so when I work with the urologist, we talk about as soon as the surgery has occurred, and within 3 to 4 weeks, pretty quickly, if not even sooner, for the man to try to get an erection. Not necessarily to be sexually active, but on their own to try and to start using the medications. Now, when do you choose and which one? Well, I'm going to show you here. Depending on the medication, you have how quickly it's going to act. So it takes about 30 minutes for Viagra to start working, about 45 for Cialis, and Levitra about 30. I think very few people use Levitra because in many ways it's so similar to Viagra, just a little bit longer action. Now the big difference is between Viagra and Cialis. Viagra wears off in about 2, maybe 3 hours, okay? Whereas Cialis continues to act for 36 hours. Now, one of the questions I get is, do I have an erection for 36 hours? No! You don't take these pills and get an erection, as you know, people who've tried them. You take the pill, and within 30 minutes or 45 minutes, with sexual stimulation, the man can have an erection. So what I like about Cialis is that you can take it in the morning and go out on a date that night, and you're not thinking about it because it continues to act for 36 hours. Or take it, you know, midday and go out at 5, and then it's going to last till the next morning. So Cialis seems to be a better choice, I think. But most men are prescribed Viagra because that's the first one that came out, and that's what everybody's familiar with. And I think this is a good place to start. This is usually when people come, this is where we start. I speak to the urologist about it. And again, with prostate cancer after radical prostatectomy, usually starting with these medications and starting to try to get an erection, the sooner after surgery that the urologist gives the man the okay, the better. Not necessarily to get an erection to be sexually intimate, just on their own to try to get an erection, because you start already basically that whole thing, if you don't use it, you lose it, that type of thing. It gets the blood flowing, and it is a good thing. Now let me talk about people who may have colon or rectal cancer or bladder cancer and have ostomies. This, I do get quite a number of my patients that I see are in this situation. And while many of them can still function sexually, okay, because some of the surgeries for colon cancer and rectal cancer no longer result in inability to have an erection or inability to have an orgasm. That's not the case. You can. But the issue is if the cases have resulted in ostomies. If you have colon cancer and you don't need a colostomy, most people regain their sexual life with time. But if you have an ostomy, whether it's for bladder or colon, which sometimes happens, not always, rarely today, but if it does, then this is where you get a lot of issues. And a lot of it is obviously very personal, and a lot of it has to do with, you know, how the person feels about having this bad. Which of course, if any of us think about it, or if you have it, it is very hard, because you're constantly thinking about this little pouch and what's in it. And can people tell? So forgetting the part about sexual intimacy, just having it, I find for most people is very difficult. Most men and women with a pouch start not wanting to go out. They think that people smell them, that people can tell they have it. Even if nobody can, they think that people can. So given that it's hard just to live your normal life, imagine being sexually intimate. So for most people, I do quite a bit of work with the person, but also if they're in a relationship with a partner, with the partner as well. Because oftentimes partners do have concerns about whether the pouch will leak or what will happen, because early on when people are learning to use these pouches, there can be accidents. So once it happens, now everybody is anxious and stressed out. So, you know, these are some of the things we talk about. There are some pouch covers that can be, for women particularly, can look sexy and they have lace on them. There's things that women can wear so it's not as visible. There's things you can do so that, again, there's less odor if they think there's odor. Again, this is something that I do work with the couples, and if it's just one person, I do have somebody that I recently saw who was single, a young woman, 32. She had been a pilot and was diagnosed with colon cancer, no family history. Really beautiful, attractive, single, and this was a big part of what was going on for her. You know, how will I ever move on with my life in terms of meeting anybody given this pouch? So what are the things that can affect you sexually? Obviously, we've just talked about cancer treatment, surgery, radiation. Other medications, I'm going to talk about that. I have a slide. Fatigue, stress. Let's talk about those two for a second. Before you ever had cancer, if you're living your life, part of your life is stress, and people get fatigued, and you're tired. So as time goes on, your sexual life, if you've been in a relationship for a number of years, will be affected just with the stressors of regular life. Work, children, grandchildren, whatever. Relationship issues, work issues. So that oftentimes, if you don't make sex a priority, just the regular fatigue and stress of regular life can really interfere with your having an active sexual life. I mean, I think that's the case for all of us. Speaking for myself, you have to really think about it. If you've been, I've been in a relationship for 24 years. So unless it's something that you think about, you know, it's just sometimes you're like, oh my God, like 5 days went by because you're just running and running and you didn't make it a priority. You're exhausted by the end of the day. So those things only become more pronounced, obviously, during treatment, fatigue and stress. Medications, I have a slide. Pain. Well, that obviously surgeries can bring about pain. Again, side effects from treatment, which I'm going to talk about. And so if you're in pain, forget that you're going to be interested in sex. I mean, if you really have a headache, you're not just saying, I have a headache, but if you really have a headache, there's no way you're going to be sexually interested because you have pain in your head. So, you know, changes in body image. I always say this is major. If you don't feel good about your body, yourself, because of what's happened with treatment, it is often very hard to then be comfortable with a partner. Changes in relationship factors. You know, I usually say that if the relationship was really not that good to start off with, cancer is unlikely to make it a whole lot better. Can it? It can, and I've seen those cases where somebody has said, the cancer came in and I've realized all of a sudden that I really want to work on the relationship. That can happen. But most of the time, if the relationship was not good to start off with, the cancer does not make it a whole lot better. It's really a struggle. So what were the relationship factors before and what's going on now? And then psychological factors. Anxiety, depression. It's hard to feel sexual if you're really stressed out, if you're having panic attacks, or you're depressed. Does anybody have any questions? Nope. Okay, what medications? Here's a list of some of the medications that can affect you sexually. There's a couple that I'm going to point out that people don't think about. Obviously, endocrine drugs, what I'm talking there is people that are on Synthroid or something like that. Antihypertensives for people who had blood pressure issues, that can affect. People don't think about diuretics or allergy medications. Okay, why would that have an impact? They dry you up. What is their job? Allergy medications to dry you up. What do they do for women vaginally? They dry you up. So if you're already dry to start off with, you're not thinking about it. You're taking that Claritin, you're taking at night, your Benadryl maybe to just be able to sleep. That's going to dry you up. And so you're thinking to yourself, oh my God, it's just become more painful. Yes, the treatment did it, but now it's worse. It's these medications you're taking, okay? They can do that. Obviously, antidepressants can. They usually don't affect your desire because when people are depressed, they usually don't desire being sexually intimate. What antidepressants do usually is make it harder to have an orgasm. Now, for men who do not have cancer or anything, if they suffer from what is called premature ejaculation, men who, according to their relationship, are ejaculating too soon, the treatment, one of the treatments, is some of the newer antidepressants, the SSRIs. Because what the SSRIs do is they delay orgasm. You can still have it, but you're going to need a lot more stimulation. So for men with premature ejaculation, that is one of the treatments, antidepressants. Obviously narcotics, because they numb you. So that's going to have an impact on you being able to have desire and also to just have an orgasm. And then alcohol. Alcohol, I think, this is a tricky one because for many people, they'll say to me, when I drink, I'm more relaxed, which is great, but it also will dry you up. So it's a tricky one. Sexual functioning involves different phases. Desire, if you have the desire, you have to have that first of all. You have to have the thoughts. You have to want to be sexual. And those just come to you. They can come even when you're not with anybody in a relationship at that moment. They can come because you're walking and you see somebody that's attractive and you have the desire. You're watching a film, you have those thoughts. If in a relationship and if intimate with somebody and you have the desire and you have enough stimulation, then you're going to have excitement or arousal, which for men is an erection. For women, you're going to have more increase in lubrication, your breathing is going to change. If you have enough of that, you can either, for some women, you're not going to have an orgasm and you're going to plateau, and that happens, okay? It can happen for men too, but most likely for women, and you're just going to sort of stay there where you're at an excited phase, but you're not going to go full orgasm. And then sometimes you do have an orgasm, and then after that, your body just sort of relaxes and you have a resolution. For women, they can go back pretty quickly and again have an orgasm. Men, usually you have to stay in that resolution phase for a little while and not immediately have another orgasm. Now I'm going to talk specifically about breast cancer. If a woman is menopausal when she's diagnosed with breast cancer and she's on hormone replacement, which is not as common today, but still is sometimes short term. Some women do take it for a few years. You know, I'm honest with this. The research has come out, and if you've not had cancer and you go through premature menopause, it is okay for a few years. I mean, I went through surgery. I avoided hormone replacement, and then, to be honest with you, I did, because just a lot of the side effects were really bothering me. And I went through the research and I saw that as long as I do it short term for about 4 years, I'll be okay. Again, no history of breast cancer per se for that. So if you are on hormone replacement and it is removed because you're diagnosed with breast cancer, you're going to get menopausal symptoms. You're likely going to get, particularly if you're young, in your early 50s, mid to early 50s, you're going to get all of the menopausal symptoms. The hot flashes, the mood changes, the sleep difficulties, you're going to get all that. And for women, if they're put into premature menopause because of some things like Zolodex, then you're immediately going to get all those symptoms. If you go through chemotherapy, and this is breast cancer, a lot of the regimens still include a drug called Cytoxan, which is an alkylating agent. So if you go through chemotherapy, and you are under 40, okay, you have about a 25 to 40% chance of going into premature menopause. Under 40, a 40% chance of premature menopause. If you're going and you're using something like Cytoxan, which is an alkylating agent, okay, and it's being used at higher doses. Now, usually, if you're under 40 and you're going through treatment, you may notice changes in your menstruation. You may get it, you may not during treatment, but oftentimes if you're, for example, 33, which I have somebody that's 33, she got it sporadically, her menstruation, during treatment, and then within 3 months it resumed, okay? So it should resume, but for about 40%, 25 to 40%, it doesn't resume. If you're over the age of 40, much more likely to go into premature menopause. So if you're 47, 48, and you go through breast cancer treatment and you get Cytoxan, you are much more likely to go into premature menopause. And premature menopause is just like menopause. If you're on tamoxifen without other chemo, you're going to have here 25% have irregular menstruation, 20% actually stop. Some will notice thinning in their vaginal lining. Some will notice a discharge. So again, side effects. Aromatase inhibitors, there's usually, and this is clinical, there haven't been the studies. So my clinical experience is that there often is a decrease in sexual desire with the aromatase inhibitors. You have these joint aches and muscle pains, and then you're going to have fatigue. And I think that it's hard to say what's causing the decrease in sexual desire, but if you're very fatigued, if you're achy, if it's hard to get around sometimes, and for some people, I've had some women who've had to discontinue Arimidex, for example, or some of the other aromatase inhibitors. If they have to discontinue it, then yeah, sometimes the side effects for that particular woman are really difficult to deal with. So, what happens when you go into menopause or premature menopause? You're going to have a decrease in estrogen and testosterone levels. What I'm talking about here, a lot of other things happen when you go into menopause in terms of your bone, cardiovascular, all those things. That I'm not going to talk about. I'm talking about what happens to you in menopause that can affect your sexual function, okay? And this is regardless of whether it's breast cancer, ovarian, or this is, you know, what can happen. You're gonna get hot flashes, very, very common. You're gonna have probably, as time goes on, vaginal dryness, pain, and tightness, because it is really the estrogen that keeps your vagina moist and helps with lubrication. You may, and this is all may, you may have changes in mood. Some women tell me, you know, I start to feel like it's a chronic feeling of PMS. Like before, when I was menstruating, it was, you know, a week out of the month. Now it seems like every day I'm irritable. It's chronic PMS, this is horrible. So other women don't. Fatigue, sleep difficulties. The sleep difficulties are sometimes or often associated with the hot flashes. I have women that sit in my office and I can see like the sweat just pouring and I see them get red. You know, for other women, again, not as bad. And then a decrease in sexual desire. When you go into menopause, testosterone is produced both in the ovaries and the adrenal gland. So the adrenal gland continues to produce a low level of testosterone. And so when you go through natural menopause, usually that continues to be there. Sometimes for women who go abruptly into menopause, the change in their desire is more marked. So I'm going to go through things that you can do for each of those things. And the reason I do is because I think that if you have bad hot flashes, that's going to affect your level of energy. It can affect your sleep. And that means it can affect your mood and it's going to affect your sexual desire. I sort of see it as this vicious cycle that can be affected. And some of the things that can help with hot flashes can also really be of great help to you for your mood as well. So, number one is exercise. And I'm going to go through that again, and I know that you guys had a talk on exercise. Exercise is one of the best things you can do, not only for hot flashes, but for anxiety, depression, sexual desire, and we'll talk about that later. And then in terms of health, it's one of the best things you can do. Relaxation exercises for meditation also can help with hot flashes, and there's studies that show that. Diet, what you eat. Herbal, I'm going to talk about that. Acupuncture works really well for some people. Research hasn't necessarily shown that it's effective, but as an individual, you should know that just because a study shows that something isn't effective in general, as an individual, it may work for you. So if it's something that's not going to hurt you and only has the potential to help you, why not give it a try if you can? So acupuncture, I've had people really report a lot of benefit from acupuncture for hot flashes, for sexual desire, for anxiety. Neurontin is a medication, but it can make you sleepy. Make-A studies show very effective, but bad side effects. And then avoid caffeine, alcohol. Why? Oh, go ahead. Were you raising your hand?
No, I was raising my hand to understand where you would get acupuncture.
Well, you would go to get acupuncture. I would try to find somebody who's used to dealing with the specific type of issues that you're having. So I don't know in this area, probably Darcy would have names of people in this area. We have people in the Miami area that we feel really comfortable referring to that are accustomed to working with people that have gone through cancer treatment. And that is a great question, because you don't want to go to somebody who starts not just doing acupuncture, but giving you a bunch of herbs, and then that becomes a problem. So I think you really do need to find somebody, and not that the herbs are bad, but again, somebody who knows what to do with the herbs. There is, one of the main things you should think about is there is now a program in this country for physicians to get certified in integrative medicine, okay? So, and non-physicians can go through this program as well. It's at the University of Arizona, and it's under Andrew Weil, W-E-I-L-L. I think a lot of you know him as the guy that trained at Harvard, the medical doctor that trained at Harvard that has that long beard and has written a lot about aging gracefully. Well, he has a program that physicians can go for 2 years and get certified in integrative medicine. So that is on the use of acupuncture, herbs, meditation, all these different types of services, but to use them in an appropriate way and not to have them interfere with the treatment. So people who've trained under him are really good resources. And there are quite a number in the South Florida area, quite a number that we have. Just in Miami, we have like about 8 people who have. So it's more and more common, and I bet there are people here in Boca as well. Specifically for some people, what to avoid. Alcohol, if any of you ever drink red wine, do you ever get hot? So that can affect you. And then what are individual triggers? Okay, for some people they have spicy food, they say that gives them hot flashes. Or clothing. Usually natural fibers are a lot better. If you wear cotton, silk, if you wear some of the polyesters and things, they can cause. Other things, staying hydrated, carry a water bottle with a spray. I have a lot of people that come into my office with the little fan and the spray from Disney World. Antidepressants. Let me talk briefly about that. If your hot flashes are really that bad, I do suggest talking to your oncologist, and you see there, talk to oncologist, about taking an antidepressant. Now, I listed 3 there. The reason I listed those 3 there is because those 3 antidepressants, not only are they good for the hot flashes, but they do not interact with tamoxifen or any other medication. Zoloft, Prozac, all of those interact with the metabolism of tamoxifen. So you need to avoid them. You often can go to a psychiatrist in the community and they may not know that those antidepressants interact with the metabolism of tamoxifen because they do not see a lot of cancer. So best to ask your oncologist because they're very well aware. And Effexor, Celexa, and Lexapro are not going to interact with the metabolism of tamoxifen. If they do, the effect is negligible, and most oncologists will be fine starting you on those. And you often can go at a lower dose than if you had depression because it can help with the hot flashes at lower doses. And also, not only will the antidepressant help with the hot flashes, but it can help with your mood, it can help with your sleep and your fatigue. So it's like a little pill that can help you with a lot. I usually tell people. And I have a lot of people that take it and say, oh my God, why didn't anybody tell me about this sooner? So.
Does it, what about those who take anti-aromatase? Because the tamoxifen is a different one.
What?
What about people that take anti-aromatase?
Oh, aromatase inhibitors? It doesn't interact. Those are safe. Totally safe with aromatase inhibitors. Now, I'm going to talk about one of the other effects of premature menopause or menopause. The main predictor of sexual dysfunction is vaginal dryness. The main predictor. This is study after study. That might be an older study, but what affects sexual functioning is still the same, vaginal dryness. Emotional well-being has an impact on your sexual functioning, body image, the quality of your relationship, but the #1 thing that predicts how your sexual life is going to go if you're with a partner is vaginal dryness. What is vaginal dryness? Dryness, itching, burning, irritation. I do have a number of women that I see where it just gets past that, where they really will tell me that it is painful. Sexual intercourse is painful. I have some women who will say that they even have some light bleeding afterwards, okay? That is not that uncommon from the women that I see. And that is due to, again, now that you have the vagina, there's not proper lubrication, the elasticity is no longer there because it's the estrogen that helps your vagina to be elastic and to enlarge when you're sexually active in intercourse. But if you're not getting that estrogen, you're gonna have your vagina where the lining is very thin, so minimal rubbing can cause bleeding, and you're gonna get where it's not elastic, so it doesn't expand. So this can be a big issue. And then if you've had radiation for like cervical cancer, they often tell women when they're going through it and afterwards to use vaginal dilators. to put them into your vagina to not allow the radiation to totally cause atrophy. Sometimes women do, sometimes they don't. Sometimes the radiation oncologists tell them to do it, and sometimes they don't. And so if it isn't done, it can be very, very painful. What to do? So I'm going to go first with the part if you have like breast cancer and you don't want to use hormones. So let's go that route first. What I tell everybody is they need to use two things for vaginal lubrication. Two things. And if you've heard this before, this does work. The first thing is you need to use a moisturizer. A vaginal moisturizer is not a lubricant. It is a moisturizer. It is no different than the moisturizer you use on your skin for your face. If you use the moisturizer on your face once every 2 months, it's not going to work. You're still going to have a dry face. You need to use a moisturizer on a daily basis to get the effects and the benefit. What do you need to do with a vaginal moisturizer? You need to use it every other day. It needs to be used every other day, and it needs to be part of your routine. It is not something that it becomes an issue if you're with a partner or if you're sexually active. Even if you're not with a partner, I recommend that you do this because it helps to prevent the atrophy that can occur. And if you get that atrophy and you get that thin lining, you can just develop like infections and it's itchy and uncomfortable. The one I like is Replenish. So that's the one I will suggest. Studies have shown that it can be as effective as estrogen cream. I don't know, but it can be quite effective. But it has to be used every other day, and you're not going to get any benefits until after you've been using it 8 to 10 weeks. So what happens?
After what, how much time?
8 to 10 weeks. Okay.
Patience.
So partly what happens, and sometimes it takes a little longer. So partly what happens is I tell women, or women have tried it, and they say to me, oh, I already tried Replenish. How long did you? Well, I used it for, 3 weeks, nothing. You didn't use it long enough. How often did you use it? Well, I used it, when I was going to be sexually intimate. No. It's a moisturizer every other day. And when do you do it? The other complaint I get is it just leaks out, right? So you need to use it right before you go to bed. It needs to become part of your routine. You brush your teeth, wash your face. Oh. You then use your vaginal moisturizer and you go to bed because you need to allow it to be absorbed. If you start walking around, it's going to leak right out. Yes, it will. So it needs to become part of your bedtime routine. So as I said, right before bed. The other part to it is Replenish comes in 2 different ways. You can get it in these pre-filled they look like little tampons that are pre-filled, and you just sort of press the bottom, boop, and it goes in. Or you can get them where it comes in a bigger package, and you have like a little syringe that you can get as much as you want. I think that if you can use the ones where you yourself decide how much you need, it's the better way to go. Because the pre-filled ones, it's too much in there. You're not going to be able to get it all in. If you do, it's going to really leak out. And it's more expensive because they're going to put more in there because they want to sell more and it's going to cost you more. So I would say you can find it on Amazon, you can find it at CVS, you can find it in lots of different places. That is just part of your routine. Whether you're with a partner or not, needs to be used if you've gone through menopause and you don't want to take hormones. Now, when you're going to be sexually intimate, you need to use a lubricant. If you've gone through premature menopause, you're not in hormone replacement therapy, you need to use a lubricant. In addition to the moisturizer. Now, my favorite, so you have KY, you have a bunch of them. I like Astroglide. That's my personal favorite. It has been Astroglide. Okay? I have it underlined right here.
I don't see well. Could you say
Oh, A-S-T-R-O, and then glide, G-L-I-D-E.
Okay.
Again, you can buy that at Amazon, online, have it delivered. Some CVS and Walgreens have it, some don't.
Publix has it too.
Publix have, see, I never even looked at Publix.
Have you ever heard of Platinum? It's a silicone base.
Yes, yes.
Have you ever tried it?
I personally, because I try most of these things myself to see. That one I haven't tried personally myself. But do you think it's good?
My
just tried it for the first time the other day, and so far I like it.
Do you like it better than the
I
Astroglide?
haven't used it enough.
Okay,
A friend of mine recommended it.
Okay.
So I'm trying that because I have plenty of Astroglide.
okay. Well, you'll let me know, and that one I haven't tried yet, so,
It's expensive, it's
What's
more
it called?
expensive, platinum, and it's a silicone base.
yeah.
This I find is
You don't like it? It's more,
tacky.
I find, yeah. And then for people,
Yeah.
right, it is a very personal choice, very personal choice. Now, I should say that with the lubricants, I think that an ideal way to use it if you're with a partner, obviously, is to use the lubricant as part of your foreplay and involve your partner in the use of it, in the application of it, so that it is not just used internally but externally as well. And oftentimes, if your partner is a male, then you might even want to put it on the penis as well. So you really want to use plenty of it so that there is as little discomfort as possible. And then for people, I've had people say, oh, but I don't want to use it as part of foreplay. I don't want to use the Astroglide. It's not spontaneous, whatever. Well, you can try suppositories, which you insert and then they melt. You can try that. I personally think better to use the lubricant, but other things, drink lots of water, which again is just helpful. Some people say vitamin E helps. Check your medications, because as I said, a lot of medications can affect vaginal dryness. And then, again, deodorant, panty liners, avoid anything that can cause irritation to your vagina. Check hormone levels. Now I'm going to talk about this more. Could be breast cancer, but generally anybody who's had any type of cancer, check your hormone levels. I have a couple more minutes here. Okay. Check your hormone levels. There are some types of hormone therapies, whether it's estrogen cream, tablet, or ring. There are women who've had breast cancer who, with working with their medical oncologist, have received like some low-dose estrogen cream, which when they've done studies doesn't seem to go systemically. And so it's something to really talk to your oncologist about. Again, they may not feel this is the initial way to go, but if you've tried everything else, like the moisture, you really gave everything else a try and it's not working, talk to your oncologist. And then for desire, there are testosterone patches and creams, but they are not FDA approved in this country for women. And part of that has to do that studies have not shown conclusively that they're any better than placebo for sexual desire. And that's the study. Now, you see all these question marks? These are things that I have personally tried with patients, okay? So I'm gonna let you know, and there's no research to back it up. I thought about doing research with it, but have never gotten around to it.
In your free time.
Huh?
In your free time.
Yes.
Yeah.
So, Marinol. Do you all know what Marinol is? Okay.
I do.
Yes. Tell them. No, go ahead, George.
It's medical marijuana and a pill.
Right. Yeah. Medical marijuana.
It's on the way out.
So it's medical marijuana. It has the active ingredient of marijuana. And it's been used for a long time. Before we had such great medications for nausea and vomiting, like you all now have Zofran and all those things. Before Zofran and those types of medications existed, Marinol was used to prevent nausea and vomiting. And it also helped with appetite. So it was used a lot more. Now we have others, and so Marinol is not used as often. So I had a patient, which Darcy probably remembers because this was many, many years ago, that was really, none of the antiemetics were working with her, none of them. And so she was really losing a lot of weight and struggling. And she was young, she was 39. And because of everything she was going through, she also had low sexual desire. So her medical oncologist, Michael Short, said, let's give a try to Marinol. We gave her Marinol. And after a week, when she comes back to see me, she says, it helped a little bit. I got a little bit of the munchies, not a lot. But what I noticed is it brought back the sexual desire and the sex that I had in my 20s when I used to smoke pot. So I said, really? Yeah. And so, yes, medical marijuana in a pill form. So, so I said to her, really? And she said, yes. You know, my husband says this pill is great. You know, I have like all this desire. I am interested, and the sex was great. So I said to her, okay. So I went back and I told the medical oncologist. And after that, through the years, the oncologists are willing sometimes to prescribe the Marinol to see if somebody has, it increases their desire or it increases their pleasure when having sexual intimacy. What I have found is that if you've never smoked marijuana and have no association of marijuana and sex, it doesn't seem to work as well. But if you're one of those people that in the 60s and 70s smoked a lot of marijuana when you were young,
But didn't inhale.
and didn't you know, smoked and had good sex when you smoked, this will probably work for you because it's sort of associated. That's been what I've been able to tease out over about 15 or 18 years of having different people try it. Because after it works for her, I've said, okay, let's try it, let's try it. And then all these people were coming back, no, I felt sort of like my head, I didn't like it. And then I started asking questions, well, did you smoke? And then I realized it's a particular group that it seems to work with. So.
That's quite a study you could do.
Yeah, right? So now, Viagra, Levitra, Cialis for women, nobody knows. The studies suggest that it does not help. But as an individual, I've had some women where it says, because it does increase the blood flow to your vaginal area. So, I don't know. Wellbutrin, if you have a side effect from an antidepressant where you're having difficulty having an orgasm, Wellbutrin at a low dose can be given to counteract that, so you can have an orgasm quicker. And Wellbutrin is the pill, do you remember a few, now it's been a while, that somebody was taking an antidepressant pill and was having spontaneous orgasms? It came out in the news maybe 10 years ago. It was Wellbutrin. Very rarely does that happen, that you take Wellbutrin and have spontaneous orgasms. But I was having all these people coming in and telling me, I want Wellbutrin, I want Wellbutrin. So, couple of new drugs that are out, Olfina for vaginal atrophy and vaginal pain. That is out, it is approved now, and it's for postmenopausal women, it's non-hormonal, and this is really aimed at the general, O-P-H-E. E-N-A.
E-N-A.
E-N-A, yeah.
Pill? What is it?
It's a pill, and it's a non-hormonal oral therapy, and it's prescribed for the general population who are struggling with vaginal dryness, do not want to take hormone replacement because of the studies that have come out, and this is something to talk to your doctor about. It was recently approved just about a year ago.
How does it work?
It's actually, how to explain it? It is sort of like some of the medications that early on came out for possibly to help with some of the side effects for like osteoporosis and things like that were non-hormonal. So it's that type of medication. It just came out this year, and I haven't had anybody really that has tried it.
But it's not contraindicated with cancer.
No, not contraindicated, but you still need to talk to your oncologist. It's not hormonal, but still talk to your oncologist. This is one that is going resubmitted for FDA approval now in February 2015. It is not out, and it's for sexual desire and arousal for premenopausal women. It's initially was developed as an antidepressant. It was not a very good antidepressant. It's an oral non-hormonal. They gave it as an antidepressant. People were still depressed, but they noticed that their sexual desire was better. So better than placebo for sexual desire. So they went back, and they're trying to get FDA approval for it, not as an antidepressant, but as something to help with sexual desire. You do have to use it for about 8 weeks, just like you would an antidepressant, because they usually don't kick in right away, and better than placebo in terms of sexual desire. But again, it is not approved. They just February 2015 resubmitted it for FDA approval. Herbal, I listed some things there, and I'm sure there are many other things that are talked about for sexual desire. Whether any of these things work or not, nobody knows. So I would talk to your medical oncologist, And if they're okay with it, give it a try. If it helps you as an individual, great. If it doesn't, then stop using it. As long as your oncologist is okay. Fatigue, very important. A lot of the same things to help you. If you're fatigued, you're not going to be too interested in being sexually intimate. So a lot of the same things we talked about. Changes in body image meaning the mental picture you have of yourself and your appearance. This, I usually work obviously with the person individually, because if you don't feel good about your body and how you look, it's going to be hard. I sometimes have a couple come in and the partner say, I think you look beautiful. I think you look great. I'm sexually attracted to you. I want to be with you. And I'll have the woman say, how can you say that? I have this, I have that. I don't like how my breast looks. I don't like how this scar looks that I had from this surgery. And so if the woman is not comfortable, then that's going to have a major impact on whether they're going to feel like sexually being intimate. Same thing with men. I have men who come in with similar things too, so I shouldn't just say women. And these are the things that I encourage, things to help them feel more comfortable about their body. The reason exercise is important is because I think that this is an issue for women, body image, whether you've had cancer or not, because of the images we get in society about how we're supposed to look. So exercise actually can just make you feel stronger. They can make you feel better about your body, can make you feel more in control of your body. So exercise with moderation, encourage. Massages, you know, just ways that you can feel more comfortable. I work a lot, again, with the individual here in therapy, and these are some of the things that I'll do. You know, can they find clothes that makes them feel more attractive? You know, if you've had a surgery and you have a scar on your belly, well, can you find some lingerie where that's not visible? What parts of your body are you more comfortable with? Well, I'm really comfortable with my legs. Okay, well then wear something short. I'm more comfortable with my breast, and they have the surgery. Okay, so wear a push-up bra, and then wear some, you know, work with what you feel more comfortable with. And I often encourage the couples to go shopping together and have fun with it. Exercise. Studies have shown over and over again the beneficial effects of exercise for sexual functioning for both men and women, regardless of cancer. And these are my last two slides. If you're with a partner, communicate, communicate, communicate. If you don't communicate with your partner, then it's going to be a problem because they don't know what's going on. I often get a partner who comes in and says to me, I haven't tried to initiate anything because I don't want to hurt them. I often haven't initiated anything because I don't want them to think that I'm only interested in sex. So the partner is going to take the cues from the person going through treatment. So you need to communicate. I'll often have a partner say to me, are they no longer attracted to me because they don't initiate? And it's like, no, it's the treatment that brings the loss of desire for this time. So communication, key. If you're going to be sexually intimate, give yourself time to get in the mood. It's not going to happen as quickly because now you've been through all this. What can help? And I'm going to list lots of things that I explore with people. Listening to music that's relaxing, even if you're not sexually intimate per se with intercourse. Touching, holding hands, dancing, kissing. Take a shower together. Watch a movie. Right, read. I think that was one of the best things.
You can go with your husband, not the girls.
But I thought the book was great. You know what I thought was great about the book? It got people talking. And one of the great things it did, it also allowed you to talk about what's normal. You know, what's normal is so, there's nothing abnormal as long as you have two consenting adults and nobody's getting really hurt, where they're getting very hurt, right, according to 50 Shades of Grey. So I thought it was just fantastic because it brought out something in the open that wasn't talked about. Usually you're going to need to allow extra time for foreplay, and this is for men and women. And sensual touching, you know, massage, communication. Oftentimes I tell people, try self-stimulation first. You know, as I said with men right after prostate cancer, try self-stimulation first. Women often don't self-stimulate. Try. See what makes you feel good before you go with a partner. Keep an open mind about sexual pleasure, positions, experiment. 50 Shades of Grey. Vibrator. No matter what people say, or no matter what, people enjoy being touched. So touching. If you're not going to go for sexual intercourse, at least be intimate. One of the things that I tell people is you may need to redefine sexual pleasure. You may need to redefine how to get and receive sexual pleasure. If you don't want to totally give up on your sexual life, then you need to be flexible. And that's really where I go with the open mind. And be patient with yourself. If there's some pain involved, limit touching, and keep sex in perspective. I mean, I've had people tell me, while our sex life has changed and it's not the same and it's very different, and we may not be as sexually active, because I nearly lost this person I love so much, the intimacy is so much more meaningful to me. So, keep it in perspective, and there's a lot more to a relationship than sex, while it is an important part. That's it.
Excellent.